Hi, this is Dr. A. This is the third video in Chapter 12 on Healthcare Ethics, using the 5th edition of the Basics of the U.S. Healthcare System and Intro to U.S. Healthcare class, and we're going to look at some bioethical issues. So first, let's have a little ethical discussion, and then we're going to dive a little deeper into this topic in a few slides. So healthcare providers who support euthanasia believe that it is an opportunity to relieve the pain a patient is experiencing at the end of their life. It's an example of an autonomy in life by allowing the person to choose when they are dying. And it allows an opportunity to be released from a life that no longer has quality. So those are the ones that support euthanasia. So let's look at the other side. Healthcare providers who believe that euthanasia is unethical feel that it devalues the concept of life and may merely be an opportunity to contain medical costs for both the families and health insurance companies. So there could be some dark motives behind it. And most importantly, a provider should not be directly involved in killing a patient because it goes against the kind of core ethical values of being a caregiver or provider. Okay, so it's a good thing to see both sides. Now, euthanasia is not legal in the United States. We'll talk about that here in a little bit. It is legal in some other countries, including Belgium, where part of my family lives. And so my aunt recently had this done. So she had terminal lung cancer, and she had to petition. So she extended her life as long as she could, and she was at a point where she was in pain all the time. And she felt like it was time, so she had to put a petition in writing for it, and it went to a board, and the board made a decision and then approved it. And so on the day, that she chose, she could pick a date, and within a certain window. And it only took from the time she decided to the time it actually happened was about a week. Okay, and so the way they did it is they gave her an injection of anti-seizure medicine, a pain medicine, and then of cyanide. And once the cyanide hit, she was dead within a minute or two. It was very, very quick. And so this was a choice. She had been talking about it for a year. She knew that that's the way she wanted to go, and it's legal over there. Just there's a certain procedure you have to follow. So there you go. That's just an illustration of an ethical discussion in both sides of the story. So let's dive into some bioethical issues. So the first one is alternative reproductive methods like in vitro fertilization, which are methods of conception that parents use to have children. And this means that the embryo is fertilized in a clinic using the sperm from the father and the egg from the mother. You can also have donated sperm, donated eggs. There can be a surrogate involved. There's a lot of different ways this can go. So some of the issues there are pre-implantation genetic diagnosis. So this can be used to test the embryo for tissue compatibility with their sibling prior to being transplanted into the mother. So you're the idea here is that the parents are making a donor sibling to potentially help an ill baby. So if one of the siblings becomes ill, then the designer baby can save the existing sibling's life by providing bone marrow transplants. If it has been determined that the embryo is not compatible, then it could be destroyed. So the motive behind this IVF is really kind of what's being in question there. This is the subject of the movie My Sister's Keeper. If you haven't seen it, it's a good one to go and watch. So this process is considered very controversial because many people consider the embryo early human life. Secondly, are the physicians and parents playing God by determining whether the embryo should be saved? There is also another issue that's related to this that has to do with what if you don't use all the fertilized embryos, if they're not all implanted into the mom, because you usually implant several, hoping that a few will take. What do you do with the leftover embryos? Are they, there's, different fates. They can be frozen, they can be kept, they can be used again in another round. They can be donated to another they can be donated to another couple who is having problems with the process. Their IVF maybe is not working. They could be destroyed. They could be donated to research, and so there's some things there you have to think about if you go choose IVF route. Also, all human beings possess stem cells, which are starter cells for the development of body tissue that they have yet to be formed into the specialized tissue for certain parts of the body. So you do have to know that stem cells are being used therapeutically now, but the stem cells that are being used are called adult stem cells. They are not embryonic stem cells. So the difference between the adult stem cells and the embryonic stem cells is the adult stem cells are already somewhat cued to what they are going to become. And they're easier to work with. Embryonic stem cells are so early in the process, it's still difficult to get them to do what we want them to do, to get them to become what we want them to become. And then you also have the thing that maybe then you're destroying embryos to use these stem cells, whereas with adult stem cells, they can be harvested from yourself and used on yourself. The term cloning applies to any procedure that creates a genetic replica of a cell or organism. Of course, then, if you're going to grow stem cells in a culture, you are going to clone them so that you have more of them. There are two major types of cloning. There's reproductive cloning, which creates clone babies, and therapeutic or research cloning, which uses the same process but is just replicating sources of stem cells to replace damaged tissues. There are several ethical issues regarding cloning. Researchers worldwide have attempted human cloning with no success. Some feel that cloning humans is unnatural and playing God rather than allowing procreation to take place naturally. Genetic testing is also carried out on populations based on age, sex, or other risk factors to determine if they are at risk for a serious genetic disease or if they have a carrier gene that they may pass on to their children. Also, genetic testing is widely available through different companies. And so the idea, again, is if employers were aware of this information, of the genetic information of a marker for a certain disease on their employee's genetic profile, would they use it to discriminate against the employee of not keeping them? Or, I don't know, there could be all kinds of different ways you can discriminate against an employee, based on genetic information. Would parents also decide against having a child because of a result of a genetic test? And then you have to get into how accurate are the genetic tests. Usually when you have genetic testing, you should have counseling that goes with it so that you really understand the tests and you can validate that they were done properly. There are no regulations regarding genetic tests, so individuals and families may make decisions based on faulty laboratory tests. And this is my world, and so I can understand a lot of times the regulations lag behind the technology. And even though laboratorians out there doing this genetic testing and putting these results out are doing really good work, and they likely are accurate, it still is a very new, evolving field. So let's go back to what we started with, the end-of-life issues. So let's unpack this a little bit more. So end-of-life issues of a patient can be an ethical challenge because healthcare providers may find this difficult to understand because they've been trained to save lives. We are caregivers, we want to care for patients, we want to keep them alive, we want them to have the best life possible. So the term euthanasia is the term that is most often associated with end-of-life issues. And there are two major types of euthanasia, voluntary and non-voluntary. So voluntary euthanasia is assisting a patient with ending their life at the patient's request. So this is what my aunt did in the example I gave you at the beginning of the video. So hers was voluntary. She had been talking about ever since she got diagnosed. She lived a whole year in this end stage. She was like stage 4 lung cancer. And this was her request. This is what she wanted. Right. Then you have non-voluntary euthanasia, which means ending the life of an incompetent patient, somebody maybe that's been in a coma, on life support for a long time, and this is usually at the request of a family member. So there's also confusion over the difference between euthanasia and physician-assisted suicide, which is now referred to as physician-assisted death. So physician-assisted death refers to the physician providing the means for death, most often with a prescription. The patient, not the physician, will ultimately administer the lethal medication, meaning the physician gives them enough of a prescription, enough of a strength that if they take a certain amount, it will be lethal. And they can, the patient then, on their own term, can decide when and where to do that. Euthanasia generally means that the physician would act directly, for instance, given a lethal injection like my aunt got of cyanide to end the patient's life. So physician-assisted dying is illegal in Maine, Oregon, Washington, Hawaii, New Jersey, Vermont, Colorado, Washington, D.C., New Mexico, and by court decision, Montana. And so I just see a typo in the slide. It says it's illegal. No, it is legal in those states. So there are several states that have put physician-assisted dying. So the Oregon Death with Dignity Act was passed in 1994 and became effective in 1997. In 2022, records indicate that 431 people had requested prescription for the death with dignity. So we have physician-assisted dying, so like physician-assisted death, which is different from euthanasia. Euthanasia is still not legal in the U.S. So as of January 2023, 278 people requested prescriptions, which included 32 from the previous year. Most patients were 65 years or older and white, which is the typical demographic since the program began. The Washington mandate was effective in 2009. It was modeled after the Oregon law, and their 2022 annual report indicates that in 2021, 400 prescriptions were requested and 291 died from taking the medication. They were enrolled in hospice care when they died, and the average patient was 75 years of age and white. So a survey of terminal patients showed they requested their prescriptions because they felt they were becoming a burden to their families, they were losing their independence, and they were losing the ability to enjoy life. In Washington and Oregon, the patient needs to be deemed terminal by 2 physicians. If physicians have doubts about a patient's mental state, a mental health professional will be consulted. The patient must make an oral request and a witness written request and another request 15 days later. The physician must inform the patient about hospice and palliative care options. So somewhat related to that are advance directives. So these are legal documents that patients give to providers to ensure that if they are terminally ill and incompetent to make a decision, certain measures will not be taken to prolong the patient's life. So it's like if they start dying, let them die. That's kind of the idea. So the patient may also include a document of durable power of attorney for health care that designates an individual authorized to make healthcare decisions for the patient. It's usually a family member, but it could be somebody else too. So an example of this would be resuscitation if the patient stops breathing. So maybe they put in their advanced directives that do not want resuscitation. So those are like what we call DNR. They do not want to be placed on breathing machines, or they don't want feeding tubes, or they don't want, do or don't want organ tissue or donation. Those are all things that can be part of an advance directive. Which then takes us to the issue of transplantation, since we just mentioned that. So transplantation is the general procedure of implanting a functional organ from one person to another. There are 2 major ethical and legal issues that are associated with organ transplants between humans. So first, it's the decision-making process of who receives the organ, right? And the second one is the money involved. So if there's financial remunerations or money is changing hands some way or another from selling organs, which then of course can result in a black market for buying and selling organs. Since 1984, as a result of the passage of the National Organ Transplant Act, it is illegal in the United States to buy and sell organs, which has resulted in thousands of Americans dying annually because of a lack of available organs. There's also an international black market for selling needed organs. But even though all of that said, there's still been continued increases in donors over the decades, but I think just our need, people are getting sicker, and so there's this increased need for organs. In 2022, 5 52,700 were on the waiting list for organs. 42,800 transplants were performed, of which a record 25,000 transplants were kidney transplants. However, there is often a wait of 7 to 10 years for a kidney. Nearly 20 people die each day waiting on an organ, and every 10 minutes somebody is placed on the waiting list. Ethical questions when making the decision as to who receives the organ. So in the U.S., there is an organ waiting list. So the questions are, should the sickest recipient waiting on the organ list receive the organ? Or should the patient who may live the longest receive the organ? So should it go to the younger one or the sicker one? Which one, right? So under the current United Network for Organ Sharing, the UNOS, patients awaiting a transplant are assigned a priority based on medical needs. So it seems to be the sickest in the U.S. that gets the transplant. So if a patient is waiting for a heart transplant, the patient who is on life support or is in intensive care will have first priority. Kidneys are allocated based on the point system maintained by UNOS, and liver transplants also include guidelines on alcohol abuse, which often destroys livers. So depending on the state, individuals may enroll in a program that gives permission for an organ harvest when they die, alleviating the pressure on families to make that decision to harvest the organs. However, in some states, you still need permission. It is required by the family, which places, of course, pressure on them, and they may go against the wish of the person. So in our state, you can put it on your driver's license, whether or not you're an organ donor, but your family still has to agree to it, and it could still go against your wishes if you were, if you were an organ donor, which is, I think, why you should really communicate with your family what your wishes are. Only 40 to 60% of U.S. families consent to organ harvesting because the media has sensationalized illegal buying and selling of organs and the unscrupulous behavior of physicians who are selling body parts for greed. Families are reluctant to grant permission. That is understandable. In other parts of the world, country use presumed consent, which means that if a parent does not actively oppose a transplantation, the procedure automatically occurs. And this is parent or family member, spouse, whichever the case may be. In the United States, the consent must be actively received from the family first. So is it an ethical policy to assume the family will consent to organ donations? Because oftentimes a family is frozen with grief and cannot make a coherent decision. So is this policy ethical to them? It's taking advantage of their grief in some way, right? So organ transplants may occur between two family members, so that brings another ethical issue. And it's usually because it has been determined that the compatibility is very high, especially between siblings, which would then results in less risk for an organ to be rejected. So it's the best option is to have a family member or sibling to be the donor. So, of course, the ethical issue with this situation is the pressure that a family member feels from the other family members to agree to give one of their organs to another family member. So it's almost like you get to be in a position where you can't say no, or you're going to be, family is going to be mad at you or something like that. Living donor organ transplant is the only field in medicine in which two individuals are ultimately involved. The person donating the organ and the person receiving the organ. Donating a kidney, when you have two functioning ones, that's a living donor organ transplant, so you're still alive. It doesn't require you dying to do that. Donating bone marrow is another example of that. So in the United States, 18 states offer a tax incentive to donate organs or marrow. These states are Arkansas, Georgia, Idaho, Iowa, Louisiana, Maryland, Massachusetts, Minnesota, Mississippi, New Mexico, New York, North Dakota, Ohio, Oklahoma, South Carolina, Utah, Virginia, and Wisconsin. Louisiana residents who donate are allowed to take a tax credit of as much as $10,000 on their state income taxes for travel, lodging, and lost wages related to the donation process. So again, is this ethical? Because in a way that is a financial incentive, so it's a form of remuneration of getting money for an organ. As a result of the increasing need for organs, there's been a black market, which is an illegal form of commerce, has developed for buying and selling of organs. The WHO indicates that there are 10,000 illegal organ purchases worldwide on an annual basis, which is considered a conservative estimate. There's probably way more than that. So procurement of body parts from poor people is also illegal in most countries in the world. It is certainly unethical, but nothing has been done because many of the organ recipients need these organs to live, and those individuals that sell the organs are making an informed choice, and they're often motivated by the need for the money. And lastly, another type of transplantation is xenotransplantation, which is the transfer of organs from one species to another. This has evolved as a result of the shortage of human organs available for donations. So like having a pig valve transplant, right? Although xenotransplantation is promising, the ethical dilemma is that we are killing animals for these procedures, which are considered experimental. Of course, then the question is there really a difference between killing animals for food and killing them for organ transplants? So there you go. So that stops the bioethical issues. We're at the end of the bioethical issues, but we have one more video coming to finish out our healthcare ethics chapter.